sort of broad context, we've been hearing in this morning session particularly clearly how states have become disempowered and non-functioning in many ways. And this is happening because of the dominance of kind of free market ideology, which really took off in the 1980s, when neoliberalism was kind of almost forced on the world by the kind of Reagan and Thatcher period. And since then we've seen states lose power because of the forced cuts in public spending that were imposed by the institutions, the World Bank, the IMF, and the World Trade Organization. And how this affects, so public goods have been devalued for 2 or 3 decades, progressively. Through the power of multinational corporations, donors, philanthrocapitalists, with the connivance of government. And this has led us to a kind of situation now where we've got failure of the state to really deliver proper services across sectors, not only health, but also education, transport, and others. And so the states are failing and being held. You can't really hold a state accountable if it's accountable to its funders and to multinational institutions. And how, so the state is failing, the market doesn't want to deliver equal services to everyone because they want to make profits, obviously. And this leaves civil society with a huge responsibility. And that's, I think, why we're here today, is to really focus on the role of civil society in ensuring good governance, good service delivery, and in the case of this, the right to health.
Decades in terms of neoliberalism. These examples right now are examples where our administration in the United States right now is actually taking a lot of power back into the government and causing a lot of a lack of access and a restriction of rights to some vulnerable groups in the US and beyond. So this is an example where the state is actually taking power and unfortunately to the detriment of people. So yeah, on that happy note, I'm going to dive right in. I kind of almost titled this talk "Health for Some" because we're so far away from universal health coverage in the U.S. right now. We're not anywhere close to it. And even the access that people do have is extremely expensive and inaccessible to a lot of people. And this is after Obamacare, so this is after a huge expansion of access to to healthcare in the U.S. And we're still so far away. But not only that, but there's currently policies in development that are implementing to limit or remove access to health services. So services that were somewhat accessible to people before are now being taken away through laws, through change of policy. And the People's Health Movement in the US and North America, as well as my organization, Health Alliance International, we're working towards health for all, which is something that's kind of the foundation for the People's Health Movement, is working towards health for all. In the face of this context where the government is working for health for some, and it's probably no surprise that the health for some include pretty wealthy people who can access health services already, and it's taking away health services from poor people and vulnerable populations. So I'm going to start out by talking about what are known as the global gag rule and the newly implemented domestic gag rule in the United States. which limits access or removes access to sexual and reproductive health services. So how many people have heard of the global gag rule? This has been around since 1984 with the Reagan administration. If anyone is involved with global health work or international aid, you might have heard of this. It was first implemented by Ronald Reagan, and it requires NGOs to certify that they will not perform or actively promote abortion as a method of family planning. So this is how it started, and it just meant that you can't use any United States dollars meant for international development or aid to talk about abortion in any way. So this was had a huge impact, of course, on a lot of NGOs who, even if they weren't working to provide abortion services in different contexts, they were able to actually talk about abortion as one form of healthcare that a woman could access. Even if it wasn't on the premises, they would be able to refer people out to abortion services. But this rule meant that nobody could talk about abortion in any context, which limited women's access to information, to education, and ultimately to healthcare, even in situations where abortion was legal. So through the years, it's been a really interesting situation because every time a Republican administration in the United States has come to power, the global gag rule has been implemented or strengthened. And every time a Democratic administration has gone into power, that global gag rule was rescinded or not enforced. So we've come up with this weird scientific experiment where we've been having US government aid being able to either talk about abortion services or not talk about abortion services, so we can see what's happened through the years to see how that's impacted women's health. And there's been a lot of studies. This is a recent one that was published in The Lancet this year in August, talking about how has the global gag rule impacted the numbers of abortions that have been happening worldwide. And it's shown beyond a shadow of a doubt that every time the gag rule is instituted or implemented or enforced, abortion rates have gone up. And every time the gag rule was rescinded and people were allowed to talk about abortion services and family planning, abortion rates have gone down. So putting these restrictions on the U.S. Development aid has actually caused more abortions than if we were able to talk and educate people about reproductive health in the first place. This is just one of many, many studies that have come out recently that have illustrated this. So the gag rule is not a small thing. The gag rule affects up to 26 million women, girls, and LGBTQI and gender nonconforming people around the world. This is a huge number of people that are lacking access to reliable and comprehensive health care as a result of this unjust policy. People without access to information are unable to make informed decisions about their healthcare options, or if they are informed about healthcare options, they're often seeking out unsafe practices, unsafe services in these contexts. Women are more likely to have unintended pregnancies, as we were just talking about. Some of these estimates are that women are 2.5 times more likely to have an unintended pregnancy when the global gag rule is implemented and enforced. And recently, under the Trump administration, on the long, long list of injustices that the Trump administration has enforced over the years, is that instead of just applying to family planning services, Trump administration has applied the global gag rule across all health services, all global health funding, including HIV/AIDS, malaria, tuberculosis, and other programs. So just as a personal anecdote, I work with a lot of NGOs in Cote d'Ivoire where our organization has a program, and these NGOs do all kinds of activities across the spectrum of healthcare. And we now have to talk to them to say, what kinds of family planning counseling are you implementing, because we receive PEPFAR funding, and if these NGOs in any way talk about abortion, the entire program would be defunded. So it's a very hard conversation to have, because I think everyone in our organization doesn't want to have that conversation, but it's just an impact of these global gag rules, and it has a real effect on the services that are provided and offered. So the global gag rule has also rolled back gains that have been made at a global level to improve women and girls' health. And the Global Fund for Women predicts that the global gag rule is going to impact up to $8.8 billion of funding. So these are all the programs across the spectrum of US funding that have anything to do with family planning or women's health. There are estimates that implementing the global gag rule causes an estimated 15,000 more women die as a result of this lack of access and information, and 8 million more unintended pregnancies every year. So I don't think I need to tell this room how awful this situation is. And it is such a bad policy that the Trump administration decided to apply it to the US as well. Title X funding is a federal grant program that's been around since 1970 to provide comprehensive and confidential family planning services and other preventative health services to up to 4 million people every year in the US. So Title X doesn't just cover family planning, it also covers breast and cervical cancer screening, testing and treatment for STIs, pregnancy diagnosis, and counseling. So this is pretty much any reproductive health service that exists gets funding from Title X. So Trump in August 2019 decided to implement a domestic gag rule. So this prohibits any healthcare providers, limits them from counseling patients on pregnancy options that include abortion. So if you've heard of this in the news recently, it's probably because you've heard that Planned Parenthood, which is one of the largest organizations that provides sexual and reproductive health services to women and men in the United States, has recently not been able to accept Title X funding, which was a huge source of their funding to be able to provide services to marginalized populations in the United States. This has affected over 300 clinics in 325 counties, spanning 33 states that have decided not to accept Title X funding because they put the health of their patients before the politics of the Trump administration. And millions of low-income women, particularly women of color, have been denied basic health services. This is because in order to access these services that they weren't previously able to access under Title X funding, they have to go to higher cost clinics, or they're going to have to pay for the entire service themselves instead of receiving subsidized services. And people may have to travel longer distances, and this has already happened, especially in the face of a lot of US states that are now limiting or removing the right to abortion services. So a lot of clinics that provided other health services other than abortion have had to close because they haven't been able to get authorization to work in these states. So people do often have to cross state lines to be able to receive health services, or they're not able to receive them at all because they become inaccessible due to cost and distance. So who is affected the most? And this is where some of the political economy of health comes in. It's probably no surprise that rich women probably have zero impact from the domestic gag rule, just as rich women have zero impact from the global gag rule. It's poor women, women of color, who are more likely to be impacted by these policies. Some studies have shown that Black women and Native American and Alaskan Native women are about 3.5 times as likely as white women to suffer death related to pregnancy. This is within the same country. Low-income women are more likely to become trapped in poverty because they are unable to access either family planning or abortion services, meaning that they might have more unintended pregnancies resulting in more children. And children are lovely, we love our children, but they're expensive. I have a 2-year-old and he is eating me out of house and home. But that's just a drop in the bucket compared to how many women and how many families are affected by these policies. We're increasingly seeing that migrant women are also affected by the lack of Title X funding and family planning and abortion services. It is an election season right now in the United States. It's kind of always an election season. I really envy some of these countries that only have 2 weeks of campaigning because we have approximately 3 years and 9 months of campaigning. It's interesting, just this morning I was listening, there was a Democratic debate. They weren't talking about abortion services this time, but they have, especially a lot of the female candidates that are in the Democratic race right now, are talking a lot about reproductive health services. And And most of them promise that on day one they're going to get rid of the global gag rule and the domestic gag rule and restore access to health services. It's important to note that even that is not enough. We really need to be expanding health services altogether. And I think that some of the more interesting propositions from the Democrats right now, including Medicare for All, which is basically single-payer, government-instituted health services, these are really interesting and exciting ideas, and I think that that is probably one of the only true paths to being able to open up access, especially for reproductive and sexual health services. So I'm going to change gears a little bit and talk about another situation that we're facing in the United States and that the Trump administration unfortunately has been limiting or removing access to health at all, and that's the human rights crisis at the US-Mexico border. So we're in a time right now, it's a humanitarian crisis across the world. A lot of populations are trying to leave war-torn areas, are trying to seek out a better life, are trying to declare asylum in different countries that are able to provide them with safety and security. The U.S. has long been a destination, especially for immigrants from Mexico and Latin America and South America. The Trump administration made it pretty clear, even before he was elected, that he was going to have none of that. Trump wanted to build a wall between Mexico and the U.S. to keep people out. So, you know, that even him saying that he's going to build a wall, even these restrictions and these dialing back of rights and access to the United States hasn't stopped people from trying. 688,000 people were apprehended by the U.S. Border Patrol between October 2018 and June 2019. So this is even in the face of these restrictions. People are desperate to leave areas where they're facing conflict and violence. Most people who are coming to the border are families or unaccompanied minors. This is different from years past when most immigration was primarily economic migrants, so people seeking employment in the U.S. Most people who are coming to the border now are people who are just trying to stay alive. Majority of the migrants are coming from Guatemala, Honduras, and El Salvador. For a while, there were a lot of detention centers on the Texas side of the United States border. The detention centers became quickly overcrowded, and they're incredibly inhumane conditions. You hear about people who are just packed in cages, like this picture here. You hear about people who don't have any access to food or nutrition or even vaccines during the flu season. It's very overcrowded. Health conditions are going untreated, and you can imagine that people who are leaving violence and conflict areas probably have a lot of mental health concerns as well. These concerns are being undiagnosed, unacknowledged, and untreated. And people are being further traumatized by being in conditions just like in this picture here. So to try to stem the kind of overcrowding the detention centers in the United States, the Trump administration instituted the Remain in Mexico policy. So this is technically called the Migrant Protection Protocol. So migrants are no longer allowed to stay in the United States while they're waiting for their asylum court dates. And more than 40,000 people have been returned to Mexico to date just from this policy. So I think a lot of people in this room already know that it's very dangerous for migrants to be waiting either on the Mexico side of the border or to return to the countries where they came from originally. There have been 340 public reports to Human Rights First, which is a human rights organization, including extortion, kidnapping, rape, human trafficking. And many migrants decide that they don't have any choice but to return to the areas which they fled from originally. So health impacts of this are profound, and I think that we don't even understand the long-term health impacts of what this policy has been inflicting on people. Children are more likely to develop profound anxiety and depression, separation anxiety, especially because children and families have been separated at the border to horrific extents. PTS, post-traumatic stress disorder, which I think is going to be something that increases over the years. Even years after people might have approached the border in the first place. Heart disease and diabetes conditions are worsened, and malnutrition, especially amongst children. So the PHM US and PHM North America have been very active in working with a lot of different groups that are both working at the border and advocating at the national level to change policies. There's a statement on our website talking about our immediate demands to halt these human rights abuses and transform the current immigration agenda. And overall, it's declaring our solidarity with migrants and hope for pursuing a peaceful life in the U.S. So I encourage you all to check out these statements. Join us. I think you can sign on. You can join us either in PHM globally in a regional chapter, or if you're interested in getting involved with some of these activities that we're doing in the U.S. as well, I'd love to have you join us. The more voices, the better.
Basically, that our discussion is political economy and social determinants. But as Luis already explained, a big political economy is a vast issues. So how can I see? I am a student of economics, and how do I see? What is the political economy? It's basically one word can say there's a critic of the capitalist economy a bit, and how it really relates people, international relations, globalizations, all the discussions around political economy. So political economy is a branch of economics that if you, as a social activist, as a human rights activist, if you don't understand political economy, it's very difficult to really push forward the agenda, people's agenda. That's important. And I was reading a small article published in Lab, good relevant to really refer to this particular discussions. This article says that the root causes of health inequalities are driven by policies that structure access to the social determinants of health. You know, the article title is very interesting. The equity of democracy matters is one page of the article, you know, last September. So you can read it, it's really interesting. Democracy matters. So that's very important. It identifies 5 different conditions, you know, that determines the health inequality, that you can say social determinants. That good quality and accessible health services. The number 2, income security and appropriate fair level of social protection. Number 3, decent living conditions. Number 4, good social and human capital. Decent work and employment conditions. So you see, all these 5 is most importantly, 2 is very important in this particular issues. Housing and living condition, low income and weak social protection. So if you just identify, because in Bangladesh we have a slogan now, after, you know, SDG adoption. The people are saying leaving no one behind. But some of the behind, those who are left behind, they are not included in the document. So we see like Dalit, you know, not included. Caste discrimination not included. The Roma community and other people we referred in the morning, Roma and others, yeah, there are many. Like Colombola in Brazil, I think, it's called Colombola. So the discrimination is set. So we have identified 36 countries that they have the same form of discrimination. It's not Nepal, Bangladesh, and India. The caste discrimination. Because if we talk about the caste discrimination, that United Nations don't listen. Because United Nations 260 million, 350 million like in disabled people, but 260 million all over the country, all over the world, that they are discriminated based on caste. So caste is not an issue for United Nations. If anything raised at the United Nations level, India is in front to prevent it. But Nepal is, you know, taking forward a bit, the Nepali government, that is good news. But recently we had a big consultation in New York. We said Global Congress on DWD. It's a new term. Discrimination based on work and dissent. So you can really cover not only caste based, you can cover more. Discrimination based on work and dissent. We form a global network now, discrimination based on work and dissent. global. Because why global? 36 countries we have identified that sort of marginalized people. I'm a bit hesitant to use the marginalization. It's a disarmament. The social exclusion is much more better word, Socially excluded. The society that does, so-called society that does exist, certain part of people, certain section of people are excluded, We keep them excluded. We keep them exclusion. So social exclusion. So, in Bangladesh, and this article also says the democracy, democracy matters. Why? If there is no democracy, I raised this question yesterday morning, that democracy does matter. Because there is no democracy, democratic institutions such as free and fair election establish the condition that empowers individual and communities. So there is no democracy in Bangladesh. We don't have any voting right. Voting right has lost. Somehow the Prime Minister wanted to continue, and he continued without the people's mandate. So now the recent situation is so bad that you cannot raise your voice. All the fears, even in one student recently, he just gave a Facebook status that, we have not received anything from India. There are a lot of agreements are there, but India is benefiting. We are not benefiting. He has been killed by the current government. So I'm saying that democracy is really matter. If you don't have voice, how can you break up? I'll highlight a bit 3-4 areas. Say Dalit people. Dalit lives in two settings. One is urban settings. Urban setting maximum, you may not know, in Bangladesh, the number of people speaks Telugu, number of people speaks Hindi, number of people speaks Bhojpuri. So there are multiple, it's a diversity. Diversity is there in Bangladesh, but we don't recognize them. And generally 10% of minority, within the minority 3% of Dalit, 3.4%. So it's 6.5 million Dalit people. It never really looked into by the human rights organization, international donors, and we started campaigning in 2008. So these campaigns helped a bit, because in 2008, when we started campaigning, that we started using the word Dalit, people are fingering us and saying that it is not an issue. Only 3 million people lives in Bangladesh, Adivashis, indigenous, living in the hill tracts and plainland, Santal. This is an issue, but you are importing something from India which is non-issue for Bangladesh. So why you are taking the Dalit issues? Our driver, I took my driver to the Dalit colonies. He said, we have something like that, the ghetto and the slums. It's like India, So they equated India, but they're living in Bangladesh, in the city, 27 colonies in the city. They don't have housing, they don't have water, as Wilson narrated in this morning. The same condition. They don't have sanitation services. They are open. They're bath, men and women. They bath openly, so they don't have anything. So that's the one special rapporteur came to Bangladesh, and we take them to the Dalit colonies, and she report back to United Nations that sanitation, water and sanitation and health system is so bad. So that's the issue, that 27 colonies in the city, all the districts, there is a colony for Dalit. Dalit is, they speak Telugu or they speak Hindi. They wanted to say them, identify themselves as origin, 8 different subcastes, they together. So this is one portion of Dalit. So they don't have, and they live isolated. And they are not allowed to enter any public services, not even tea shops. And in rural areas, the Bengali speaking Dalit. So altogether 6.5 million. Those who are poor Dalit, they're showmaker, pig rearers, and many different occupations traditionally they are doing. So their basic, their low income, the housing condition that I narrated, the 5 different conditions, is really so bad. So how can they really claim their health services? If they really visit the health services, the doctors do not touch them. So doctors do not touch them even. So when doctors do not touch them, then I was started telling that why don't you establish a separate hospital for these particular communities? That is not the acceptable where the people say the mainstreaming. If you are not allowed to the schools, in classes. Even if they get the admission, the people say, oh, sit in the back and go to the toilet to clean the toilet if the students come. So if you are not allowed in your space, so why don't you create a different space for time being? So that's, otherwise how they will not get any services. The condition is so bad, the education is so low, they are traditionally, their traditional occupation, their ancestral occupation, cleaning jobs and other jobs. And a bit successes we have started campaign in 2008, as I said. When the political parties started writing their manifesto, we went there to really put at least one line that if we come to the power, we'll do something for the Dalit communities. So, yeah, they said we cannot write one line, say one word. So I said, write Dalit and Prantik Janagoshti, that's a marginalized community, will do something. So they wrote it. Fortunately, that party came to the power. And immediately after taking oath, we rushed to them. First 100 days program, what you are going to do for the Dalit. So, good news is that I know the finance minister personally, and the budget session in June, it's generally on the 7th June. So I got a letter from the Ministry of Finance that 10 crore taka allocated for housing for the Dalit. So this is the first history we started campaigning. So I think that now we have different groups in the district level, they are playing. So I'm saying that success is there if you awareness, leadership building, and lead by their own leaders. The community-based driven things that can happen. So this is one Dalit, but health services I can narrate, but there is no special health service. There are untouchable practices, untouchability practices are so huge, they doctor donors. So one cases you will understand that. She is the now Bangladesh Dalit and Equality movement president, after 10 years of struggle. And her elder son worked with a dentist. So one day, some dash. So dentists do not understand, he is from the sweeper colony. And he is somehow managed to intermediate level of assistant, intermediate level of education. So one day, he took her mother to treat the same doctor because he worked with him. So the treatment is over. Sometimes they close like 11 or 11:30 after the chamber. So why don't you go with me? I will put you in your house, on the way. So sometimes that happens. I said, no sir, you just keep me. No, I want to go to your home and want to drop you there. No, I can go by this, take rickshaw. So he is hiding that while he lives, it's a silver colonies. One day that Munirani was inviting from the national media to talk, on Dalit issues, because of our movement. And suddenly my wife and I was watching the television and found I cannot really, how can I recognize the Muni because so painted or some way of dressing. So immediately after finishing the talk show, I called her. Why you are painted like this? She don't want to say this. She said, my son told me, Ma, don't want to identify yourself. If my boss see you in the television and knows that you are from the Dalit colony, I will lose my job. So that sort of things is there. So this is the Dalit issues. And Dalit and tea garden workers, we have the tea garden. It's the same condition because I was one of the international fact-finding team in Assam and tea workers and Assam and Darjeeling areas. So it's worst in Bangladesh as well. Tea workers is a bonded labor. They have a hospital. But that hospital do not have any qualified doctors, and they are not allowed to even go out of and their earning is a bit less than $1. $1. Now is it the $1? $1.50 or something the daily rate. So this is the tea garden workers issues, and again I'll be short, So and then Rohingya issues as mentioned in this morning. Rohingya issues, as you mentioned, your condition and the Mexican border. But in Bangladesh, now Myanmar and Bangladeshi border, 1 million people, living in this particular condition. The thing is that many of the young children, they lost their parents. So they are orphan, right? And newborn babies are there, women's health rights. Health rights is huge issues for the Rohingya people. I visited 3-4 times there. Government's worker again is one of the marginalized communities. They earn only $100 a month. $100 a month. So $100 they live in a place in slum areas, and they are the gender-based violence. We did a study recently, gender-based violence, and we will try to collect information from 3 different areas, like a home they live in, and they commute, and the workplace. So we found that serious gender-based violence and sexual abuses and other things. And they cannot spend their money for the health. Only 50% of their, 50 to 60% of their money is spent for house rent because they live in the city. So, and the basic amenities. So now we always tell them that, are they marginalists? This is my question. Are they poor? Are they ultra poor? That we really try to identify themselves. So I want to say that it's a social exclusion, definitely. And different determinants, a structural problem. The least, if the least have the money, even can rent by one building in Dhaka city, they dismantle and build a new colony, new housing plan for the government, and they wanted to go out, find some of the places to rent out. So there is a signboard in the outside saying, we don't rent out houses for the sweepers. So that's a decent event. So they do not go out to rent houses, rent any house. So we are discussing all the time the social determinants. There are other determinants is really huge, like structural determinants we need to discuss on not only class point of view, not only poor and rich and income equalities, where the social determinants of the disability practices, and the environmental and climate change is a huge determinants now for health issues that we need to discuss. I have not seen any session on these particular areas. Then excessive use of pesticides and chemicals in the food, production. So that is damaging for health. So we need to really discuss more broadly what are the other determinants that really exclude the people.
I work in Chhattisgarh, which is a state in India which is facing conflict in terms of left-wing, the left-wing so-called banned parties which are fighting a militant battle against their claimed their stated position. And since I was going to speak about conflict and how we have been dealing with it in Chhattisgarh and the impact that it has had on health and what we've seen on the ground, I thought it would be appropriate to, since Kashmir is a lot more documented, I thought we'd look at it at the condition in Kashmir today. And like we know, regarding the entire episode right now that is going on in Kashmir, and with the focus on health, what was in the news that we know of was this particular article that came out in the Lancet journal, in which the Lancet took this view that this move by the government to remove Article 370 and to take away Kashmir's autonomy was a very negative move, and in which in that particular piece they had quoted from the UN body which had stated that a large number of extrajudicial murders have taken place, encounters, disappearances have taken place, and they had also quoted from this MSF study which had found that there is a huge mental health crisis in Kashmir, and according to their study, what they had found was, their study conducted in 2 districts, what they had found was that about 1.8 million people of the 8 million people in Kashmir suffer from some form of mental health illness. Yeah. So there's that one aspect of public health that we speak about, and there was news about how the whole health insurance schemes, which presently our whole public health system seems to be based upon, has come to a complete halt in Kashmir because of the breakdown of the internet services, etc. And then we also heard news about how professionals, public health professionals from Kashmir, when they tried to raise the issue of shortage of drugs and the issue of lack of accessibility for people in Kashmir, and for that also, this had also come out in the media reports that the police had taken away this particular doctor. He was picked up by the police when he raised certain. Some of them are not, and similarly, there is one major consequences of violence is disability, and then what we find is like sexual violence by the forces among the villagers. There have been a few cases in the recent past of rape and sexual violence by the forces against the villagers there. And then there is the issue of displacement because of this violence. So the estimates are about that 1.5 million people have been affected and displaced by this conflict in Chhattisgarh itself. And then the whole mental health issue is something that we face and which is not documented at all. And you'll find that scores of villages, it has completely disrupted normalcy and normal life, and people can't go about their lives normally. And so there are mental health issues. And then another thing that we find is mental health of the police and paramilitary forces as well. We find that there is a very high suicide rate among the forces that are posted in the conflict areas in Bastar, and there is a very high rate of suicide among them as well. So we are involved in a lot of these cases that I mentioned, these human rights cases of sexual violence and of other issues. And apart from that, if you look at the whole public health system in these conflict areas, so there was this particular litigation initiative that we had taken up, and this was regarding the public health services in this particular district in Chhattisgarh, which is called Sukhma, which is a conflict area, and it is the southern part of Chhattisgarh. And it led to this case in the court led to appointment of medical personnel. And the court, the High Court in Chhattisgarh, that is at Bilaspur, it went on to say that the fact that a particular area is a conflict area does not absolve the state from providing medical services in that particular area. And they also went on to say that the state must also not be apprehensive of, say, private non-governmental agencies that want to work in these areas, because there has been some history of the government asking the non-governmental agencies who work there, humanitarian agencies who work there, they're apprehensive of them working in these areas. So the court was very particular about that if people want to work there, humanitarian agencies want to work there, then it is the government should not stop them from doing that. Yeah. And another thing that I was going to speak about is the particularly vulnerable tribal groups in Chhattisgarh in terms of their autonomy and what the public health system in Chhattisgarh, their position in the public health system in Chhattisgarh. It's written in Hindi. So there was this initiative that we took, the People's Health Movement Chhattisgarh and HRLN together. So this was in the 1970s when the government of India was following an aggressive population control policy where they were aggressively implementing population control measures, and they were forcing people to get sterilized, etc. So at that time, the government decided that there are particular tribal groups whose population is on the decline, and they decided to impose a ban on their sterilization. So in the year 1979, the government basically passed an order saying that tribes, people who belong to certain particular tribes, they are not allowed to access any form of contraception. So this led to a huge, this has led to injustice for a large number of years. So since 1979, what you basically had was these particularly vulnerable tribal groups being denied, being completely denied any form of contraception. So, so 10 women from this particular tribal group, along with the PHM, we approached the Chhattisgarh High Court, and these were basically women who said that we have 10 children, and we are poor, we're victims of domestic violence, and we're not able to raise these children on our own. But we cannot undergo a sterilization operation because of this particular ban. So we challenged this 1979 order, and which was struck down by the court. It seemed like a simple case because the Indian Supreme Court has categorically held that reproductive rights are part of your right to health, and they've said that how many children you want, the spacing between children, etc., is a part of your reproductive rights. So this was a given. In spite of that, this rule was law for such a long time. So finally, it was in 2000 and last year that the High Court struck this rule down. Now finally, all particularly vulnerable tribal groups have access to all forms of contraception, including sterilization. And there are a few other examples that I wanted to discuss briefly about the kind of cases that we've done. For example, this is a health center at Gorela in Bilaspur, which is also predominantly a tribal inhabited villages. And here also we had approached the court saying that proper health services are not available in these areas. So when we go to court and when you indulge in this sort of a litigation, you do come across what we've been discussing, the disempowered state, where the state even telling the court that yes, your fundamental rights are there, you have these beautiful pronouncements by the Supreme Court, but we don't have the resources to do it. But it's like a bargaining process in the court where the court tells them, can you do this, can you do this? So it's like a bargaining thing, it goes back and forth, and ultimately you do get a bit out of the bargain and things do improve a little in the hospitals that I've seen. And another thing that we've done is that, in law, they do say that for these particular groups, say the PVTGs or the tribals, the standards will be different. Or say if the IPHS says something for the other areas, for tribal areas, you will have indigenous people, will give you something more. But in practice, that does not happen. So we've often gone to court saying that, see, this is a village that is inhabited by the indigenous people, by the particularly vulnerable tribal groups. So you should be doing more than what the regular standards say. So sometimes we've been successful where the population norms are not met yet. The government has gone ahead and opened different centers, be it Anganwadi centers or hospitals, etc. So there is some sort of success when it comes to that. This is another case that we had done with PHM. This was regarding ill treatment of this woman at the health center, and the National Human Rights Commission awarded a compensation of 1